Cardiac biomarkers. Welcome back, students. This video focuses on basics of cardiac biomarkers for MBBS students. I suggest that you should pause and replay the segment in the video that you are unable to understand in the first go. If you still have difficulties understanding the concept, you can add it to the comments below the video. Let's begin. Plasma or serum biomarkers can be measured to assess myocardial dysfunction and ischemia. Biomarker for myocardial dysfunction is brain natriuretic peptide, which is popularly known as BNP, and its more sensitive version is N-terminal proBNP, also called NT-proBNP. Biomarker for myocardial ischemia is troponin. There are two main troponins used as biomarkers, troponin I and troponin T. Either one of them can be used and both carry same prognostic significance. Brain natriuretic peptide. Brain natriuretic peptide is also referred to as B-type natriuretic peptide. It was discovered in 1988. It has established itself as a biomarker for the diagnosis of congestive heart failure. It is extremely helpful in acute care settings for the diagnosis of congestive heart failure in patients with undifferentiated dyspnea. BNP is a member of a family of 4 human natriuretic peptides that share a common 17-peptide ring structure. In 1983, atrial natriuretic peptide or ANP was first to be identified. ANP is secreted in response to atrial stretching. Elevated ANP is found in LV hypertrophy and mitral stenosis. BNP was identified in pig brains in 1988, therefore named brain natriuretic peptide. BNP was subsequently discovered in ventricles. CNP and DNP have also been described, and they act in peripheral vasculature and atria respectively. BNP is stored as a 108 amino acid polypeptide called proBNP in both ventricles. It is secreted in response to myocardial stretch. ProBNP is cleaved into BNP, which is the active part. BNP is a 32 amino acid peptide along with a biologically inert 76 amino acid NT-proBNP. Both fragments are secreted into plasma in equal numbers. The latter is diagnostically more useful, as it has a longer half-life. It is elevated principally in conditions associated with left ventricular systolic dysfunction and may aid the diagnosis and assess prognosis and response to therapy in patients with heart failure. ANP and BNP have diuretic, natriuretic and antihypertensive effects exerted by inhibiting renin-angiotensin-aldosterone system. They also have systemic and renal sympathetic activity. Receptors and endopeptidases actively clear BNP from the circulation. Half-life of BNP is 20 minutes. NT-proBNP does not bind to receptors and thus has a half-life of 1 to 2 hours. This is why plasma levels of NT-proBNP are 3 to 5 times higher than BNP. Clearance of NT-proBNP is primarily renal. Therefore, reliability of NT-proBNP decreases in CKD patients. NT-proBNP samples are stable at room temperature for 72 hours, whereas BNP samples remain stable for only 4 hours. Assay methods for BNP and NT-proBNP. First-generation assays were radioimmunoassays that required purification of plasma sample. Second-generation assays had monoclonal antibodies and radioisotopes. These assays required up to 24 hours to complete. Third-generation assays provide results in 15 minutes and are based on immunofluorescence methods. NT-proBNP and BNP are both useful for diagnosing overt congestive heart failure, but NT-proBNP is more sensitive for diagnosing early LV dysfunction. Recombinant form of BNP has been synthesized and is called nasiratide. It was approved for use in acute decompensated heart failure. In patients receiving nasiratide, which is a recombinant form of BNP, we measure NT-proBNP and not BNP levels to diagnose and prognosticate heart failure. The cutoff levels for BNP for diagnosing heart failure are more than 500 picograms per milliliter, and levels less than 100 picograms per milliliter are useful for ruling out heart failure. Similar cutoff levels to diagnose heart failure using NT-proBNP are more than 450 picograms per milliliter for those between 21 to 50 years of age. For those above 50 years of age, this cutoff for diagnosis is more than 900 picograms per milliliter. NT-proBNP levels of less than 300 picograms per milliliter are taken to rule out heart failure. This much knowledge about BNP and NT-proBNP will help you diagnose and interpret the levels of these biomarkers in your patients. The science of biomarkers is an evolving science, and you will need to keep updating yourself about the newer, more sensitive assays as well as various clinical diagnostic algorithms that use one of these biomarkers along with the history, clinical features, NYHA classification and so on. Next we move to another biomarker used for diagnosing ischemia in cardiac muscles. Now, the next biomarker is cardiac troponin. Troponin I and troponin T are structural cardiac muscle proteins that are released during myocyte damage and necrosis, and represent the cornerstone of the diagnosis of acute myocardial infarction. Three types of troponins exist: troponin I, troponin T, and troponin C. Each subunit has a unique function. Troponin T binds the troponin components to tropomyosin. Troponin I inhibits the interaction of myosin with actin. And troponin C contains the binding sites for Ca2+ that helps initiate contraction. Troponins are released in response to myocardial injury regardless of cause. Ischemia is the most common cause of cardiac muscle damage. When measured with older generation assays, elevated troponin levels can be detected 6 to 12 hours after onset of myocardial injury, peaking at about 24 hours, followed by a gradual decline over several days, up to 2 weeks. Modern assays can detect troponins as early as 3 to 4 hours after onset of myocardial damage. However, modern assays are extremely sensitive and can detect very low levels of myocardial damage, so that elevated plasma troponin concentrations are seen in other acute conditions. Causes of troponin elevation other than MI include the following: myocarditis, pericarditis, cardiac trauma, pulmonary embolism, aortic dissection, cardiac arrhythmias, tachyarrhythmias, bradyarrhythmias, heart blocks, cardiopulmonary resuscitation, defibrillation, chronic severe heart failure, endocarditis, cardiac surgery, stroke, ischemic or hemorrhagic, sepsis, chronic kidney disease, burns, extreme exertion as in marathon, doxorubicin, snake venom, critical illness. The latest generation assays of troponin are called high-sensitivity troponin assays. The cutoff value taken for high-sensitivity troponin assays is 99th percentile of normal population values. These assays must have a coefficient of variation that is less than 10% at the cutoff value. The limit of detection of these assays should be well below the cutoff values so that greater than 50% of the normal population gives some measurable troponin levels. The cutoff value will differ with gender, race and age. Conventionally, troponin was measured qualitatively using card tests. The cards will give positive result if troponin concentration is greater than 100 nanograms per liter. The high-sensitive troponins can detect troponin levels of as low as 5 nanograms per liter. The 99th percentile value for troponin T is 14 nanograms per liter. This means any patient having troponin T levels of more than or equal to 14 nanograms per liter is having myocardial injury. For troponin I, this 99th percentile value varies from one assay to another and varies from 10 to 30 nanograms per liter. Therefore, the qualitative cards are not to be used for diagnosis of myocardial injury, as they will miss many cases of early myocardial injury where levels may be below 100 nanograms per liter. We will study the details of the troponins and their interpretations when we cover chest pain and myocardial infarction. With this, we come to the end of this lecture on the basics of cardiac biomarkers for MBBS students. Hope you enjoyed the video. For more videos like this, do not forget to like and subscribe the channel. Do post your comments and queries related to the topic. Also, suggestions are invited for the improvement of videos in future.